Today we are going to talk about what I think every healthcare provider should know about child physical abuse. The goals of this talk will be to understand the scope of child abuse on a national level, understand your role as a healthcare provider and mandated reporter of suspected child abuse, understand your role as an advocate for the protection of children, realize that physical abuse often presents with very nonspecific symptoms, recognize certain red flag historical elements when evaluating children who are suspected victims of child abuse, recognize why infants and toddlers are at the highest risk for severe injuries, become familiar with some common triggers for abusive behavior against infants, toddlers, and school-age children, and become familiar with some common diagnostic tests that can be of help in evaluating children who are suspected victims of child abuse. Unfortunately, child abuse is not a rare occurrence. Here are some data regarding the prevalence of child abuse nationally, taken from the Child Maltreatment Report in 2012. During the federal fiscal year 2012, CPS agencies received near 3.4 million referrals, which involved the alleged maltreatment of near 6.3 million children. More than 2 million of those reports received, or near 60% of the reports received, were screened in for assessment by CPS agencies. Almost 60% of all reports were made by professionals, including law enforcement, legal personnel, educational personnel, social service personnel, and medical personnel. Out of all of these cases, 686,000 children were determined to be confirmed cases of abuse. This graph displays the percentage of children by age who were victims of abuse in 2012. As you can see, according to this data, the youngest children, less than 3 years old, make up the largest percentage of victims. This next slide displays the percentage of types of maltreatment seen in 2012. Clearly, neglect represents the largest percentage of cases of abuse, followed by physical abuse and sexual abuse. One of the most devastating consequences of child maltreatment is death. In 2012, 1,640 children died due to child abuse and/or neglect nationally. Of these fatalities, near 70% were younger than 3 years of age, again showing that the youngest children are most vulnerable to death as a result of maltreatment. Near 70% of the fatalities suffered neglect, and just over 40% of child fatalities suffered physical abuse, either exclusively or in combination with other forms of abuse. As you can see by the most recent national data, child abuse is not at all an uncommon problem. Thus, it is imperative for all healthcare providers to be aware of their roles and responsibilities in identifying, reporting, and preventing child maltreatment. All healthcare providers are mandated reporters by law. In other words, there are statutes in all 50 states that identify persons who are required to report suspected child maltreatment to an appropriate agency, like Child Protective Services, a law enforcement agency, or a state's toll-free child abuse reporting hotline. Failure to do so can be a criminal offense. Despite these statutes, there are still some known barriers when it comes to the healthcare provider reporting suspicions of abuse. A study done in 2008 called the CARE Study, which stands for the Child Abuse Recognition Experience Study, looked at this and found that both primary care physicians and nurse practitioners who treat injured children find the decision of whether to report suspected abuse difficult. Some of the reasons included the provider having a lack of certainty that the child was abused, the child presenting with unusual or nonspecific complaints that may not be recognized as signs of abuse, the provider perceiving the importance of maintaining their familiar relationships higher than their suspicion of abuse, and the provider having an overall distrust of child protection agencies. When faced with the decision of when to report concerns of maltreatment, remember, you are not required to prove abuse before you report it. Having the concern means you are legally obligated to report it. Failing to recognize and report suspicions of abuse too often result in significant morbidity and mortality. Children who are abused, when returned to the same environment without appropriate intervention, will return with more serious, escalating injuries, and in the worst cases, death. We are now going to change our conversation to explore the role of the healthcare provider. Healthcare providers are charged with providing appropriate care for their patients. In children who are suspected victims of abuse, a healthcare provider's role should include prevention, detection, and medical management. In order to accomplish this, healthcare providers must maintain a high index of suspicion. Keys to doing this effectively include recognizing that child abuse occurs commonly, that child abuse can occur in families from any socioeconomic, class, ethnicity, or community. Being a nice family, or a family that is well known by the healthcare provider, does not exclude the possibility of abuse, and that abuse must be part of the differential diagnosis in all childhood trauma. When gathering historical details, ask yourself if what is being relayed makes sense with what you are seeing. Elements of the history should raise a red flag. Some of these elements include when no history is offered for a child's injury, when the history doesn't match the degree or pattern of injury, when history is vague or lacks detail, when history changes or is contradicted when relayed by other caregivers or by the child themselves, when the history is not consistent with the child's developmental ability. Additionally, there are certain physical findings that should alert the healthcare provider as to the possibility of child abuse. Any bruising in an infant who is not mobile is concerning. Those who don't cruise don't bruise. Bruising in the 10-4 locations is of concern. 10 represents torso, ears, or neck. 4 represents any bruising anywhere on a child 4 months or younger. Patterned bruising, where there may be linear marks or handprints, and subconjunctival hemorrhages. While these are often seen several days after birth, they should raise significant concern in an infant past this time period. This finding is a well-documented sentinel injury. A sentinel injury is a previous injury reported in medical history that was suspicious for abuse and preceded more severe abuse, and frenula tears in non-mobile infants. In addition to recognizing important historical details, the healthcare provider must also be aware of non-specific signs that can be associated with occult injuries, especially in infants and young children. Some examples are vomiting, especially without diarrhea. This could be an indication of head injury or abdominal trauma. Poor feeding. Tachypnea with irritability. This could be an indication of occult bone injuries like rib fractures. Grunting respirations with irritability. Fever with irritability. Inconsolable crying. Decreased tone or limpness. Stiffening and staring spells, or apparent life-threatening events, also known as ALTIs. All of these could be indication of head injury. Additionally, there are certain physical findings that should alert the healthcare provider as to the possibility of child abuse. Any bruising in an infant who is not mobile is concerning. Those who don't cruise don't bruise. Bruising in the 10-4 locations is of concern. 10 represents torso, ears, or neck. 4 represents any bruising anywhere on a child 4 months or younger. Patterned bruising, where there may be linear marks or handprints, and subconjunctival hemorrhages. While these are often seen several days after birth, they should raise significant concern in an infant past this time period. This finding is a well-documented sentinel injury. A sentinel injury is a previous injury reported in medical history that was suspicious for abuse and preceded more severe abuse, and frenula tears in non-mobile infants. This slide shows some pictures of concerning injuries. In the upper left-hand corner is a small 6-week-old infant who has a small round bruise to her upper outer arm. This particular infant was later found to have intracranial bleeding with brain tissue injury, severe retinal hemorrhages in both eyes, and several fractures. The picture next is a toddler with patterned bruising. This appears as a handprint to the upper outer thigh. The following picture underneath is a picture of a 4-month-old infant with subconjunctival bleeding to the whites of his eyes. This infant, upon further evaluation, was found to have several healing rib fractures. And finally is a picture of bruising to the outer pinna of the ear in a toddler. Other elements that you should keep in mind when evaluating children and the possibility of abuse is that trauma is rarely offered as the reason for the presentation. Nonspecific signs are not always going to be a viral illness, colic, reflux, or constipation. Keep physical abuse in your differential diagnosis. Performing thorough histories and physical exams are key in helping identify potential victims of abuse. Subtle physical exam findings can be major clues in helping to identify a maltreated child, like we saw in the prior slide with the 6-week-old infant. And relatively unimpressive surface marks and injuries may be associated with far more significant underlying trauma, especially in young infants. Another very important role of healthcare providers is prevention. Providers can educate parents regarding the range of normal behaviors in infants and children and provide appropriate anticipatory guidance. Healthcare providers need to be aware what age is at highest risk so they can help provide caregivers with appropriate advice and guidance. Infants and toddlers are at highest risk for abuse. This is because they are unable to escape attack. They're small and immature and thus more vulnerable to severe injury. And they are developmentally incapable of meeting many of their caregivers' expectations. Additionally, being aware of the common triggers that can lead to abuse in infants, toddlers, and school-aged children can aid the healthcare provider in counseling caregivers appropriately and allows the healthcare provider to be a resource when behavior becomes unmanageable for caregivers. Some common triggers for abuse in infants are prolonged crying, inconsolable crying, feeding problems, vomiting, messy diapers, developmentally inappropriate expectations, and interrupting the parent. Some common triggers for abuse in toddlers are toileting accidents, getting into things they're not supposed to, stubbornness, saying no, and developmentally inappropriate expectations. And some common triggers in school-aged children for abuse are defiance, oppositional behavior, getting in trouble at school, and developmentally inappropriate expectations. Now that we've discussed when one should have suspicion for child abuse, let's move on to discuss what the medical evaluation should look like. As discussed, the healthcare provider must complete a thorough history in helping to construct a differential diagnosis, one that includes the birth history, past medical history, surgical history, review of allergies, immunization status, and medical history, a developmental history, family history, and social history, as well as completing a complete head-to-toe physical exam. There are also some essential diagnostic tests that can be helpful in your assessment, one of which is the skeletal survey. This study is a minimum of 21 plain X-rays in the AP, PA, and lateral positions to evaluate the entire skeleton for any occult injuries. It is considered mandatory in all cases of suspected physical abuse in children less than 24 months of age and should be strongly considered in other scenarios. Some of those scenarios include any child who is less than 12 months old with a fracture, any child with severe or extensive fractures, any child who has a history of prior fractures more than one, any child who has a history or has a family history of soft or easily broken bones, and any child older than or equal to 5 years of age who is not developmentally and or physically capable of giving a history or indicating areas of injury or pain. Another important diagnostic test is head imaging. This is also considered mandatory in all children less than 6 months with suspicion of physical abuse. A non-contrast head CT is a good first study, while a brain MRI is best for detecting subtle injuries. In some cases, both studies should be performed. Depicted in this slide are examples of head injuries in an infant. The head CT shows a left-sided subdural bleed with associated swelling and edema, resulting in the loss of the left ventricle and shift of the brain to the other side. The brain MRI shows large subdural blood collections on both sides of the brain. Certain laboratory tests can be helpful in determining if there are any underlying medical problems in a child when there are concerns for maltreatment. When concerned about whether a child presenting with multiple bruises and/or intracranial hemorrhage has a bleeding disorder, the following screening tests can be helpful: CBC with differential and platelet count, PT and INR, APTT, retic count, fibrinogen, TCT, von Willebrand activity and antigen and D-dimer, factor 8 and 9 assays, factor 13 screen, and a platelet function analyzer test. When evaluating for abdominal trauma, dehydration, or rhabdomyolysis in a child who presents with other traumatic injuries or nonspecific signs, the following screening tests can be helpful: a complete metabolic profile, amylase, lipase, CPK, atolase, and a urinalysis. When evaluating a child who presents with multiple fractures and metabolic bone disease is a concern, the following screening tests may be helpful: an intact parathyroid hormone level, total calcium, phosphorus, alk phosphatase, 25-OH vitamin D level, or genetic testing, specifically for osteogenesis imperfecta. And finally, when evaluating a child who presents with altered mental status, consider obtaining a comprehensive urine drug screen, a urine drug abuse screen, and other specific toxins, depending on the information that is gathered from the elements of the history. Also keep in mind that consultation from appropriate subspecialists may be helpful, including hematology, orthopedics, endocrinology, geneticists, neurology, neurosurgery, pediatric radiology, and the child abuse pediatrician. In Indiana, you can report suspicions of child abuse to the Indiana Child Abuse and Neglect Hotline at 1-800-800-5556. The hotline is available 24 hours a day, 7 days a week, including holidays. While reports can be made anonymously, it is important for the healthcare provider to be aware that representatives from DCS may very likely need your help and guidance in fully understanding the issues of concern. Some other points to keep in mind when you suspect child maltreatment are that when one child is identified as a suspected victim of abuse, the siblings and other child contacts of the suspected abuser should also be assessed for injuries. That physical abuse is repetitive and escalates over time. Therefore, early recognition, reporting, and intervention of child abuse is essential to preventing increasing morbidity and mortality. As caregivers of this vulnerable population, the healthcare provider is vital in this role.